Okay. So nice to be with you for this fourth session of EUS Confluence Days 2021. And this day is mainly dedicated to therapeutic EUS. So I'm very pleased to introduce the moderators, Professor Linda Lee from USA and Professor Geoffroy Van Bervlet from Nice in France. So thank you to be with us, and I let you the talk.
Thank you, Mark. It is very great to see you again, and I am very happy to moderate this session with Linda. Hello, Linda. Hello, everyone. So up to see you all, not with the screen, but physically and rapidly, if it is possible in the future. So, Mark, you will start this session with a very interesting lecture, I think, about US-guided gastrojejunal anastomosis. You will be you have been one of the first operator with modern CASHAB to perform this kind of procedure. So I think you are the best to talk about it. So let's go for your talk.
Okay. So you think it will be interesting, and I hope it will be interesting. So, so I'm going to start, not to lose time. I will speak about EUS-guided gastrojejunal anastomosis, and you will see there's other tools to do gastrojejunal anastomosis endoscopically, not only EUS. I will provide a few slides at the end of the presentation. So this is a view from Marseille, from the Vieux-Port, from my hospital, and from what we call the Calanque alongside the sea. And I do a lot of mountain bike here. Okay. So EUS endoscopic guided gastrojejunal anastomosis you can do with magnet tools. It's done by Christopher Thompson, and NOTS procedure I will show you. And EUS guided can be done by direct gastroenterostomy, balloon-assisted gastroenterostomy, which was initiated by Moen Kashab, and double balloon occluded gastroenterostomy done by Itoi in Tokyo, in Japan. Okay, so just to say that ESG guidelines will be soon available. We are just working hardly about it, and we have nearly finished for July, and I think in September it will be ready. So we have mainly two means. We have some other means, but mainly two means to perform.
Sorry, Professor Barker, you need to share your slides.
Okay, we don't
okay,
have
you have not my slide?
No, we don't have it.
I don't understand why, because I am on my slide. Okay, so I will do it again.
I don't know if it's not a problem with the general presentation of the slideshow, not your PPT. I think it's not the problem.
And now you have it?
Yeah,
yes.
Now we can see.
Put it on the slideshow. Yes.
It's okay.
Perfect.
It's okay.
Parfait.
Okay. Perfect. Okay, thank you. Okay, this is my city, and this is the Calanque, and I told you that we can do endoscopic gastrojejunal anastomosis with NOTS and EUS guided directly, or balloon or double balloon assisted. Okay, so how to choose between direct approach, which could be assisted with a slim scope to fill the duodenum with water, saline, or blue, methylene blue, or insertion of a nasobiliary catheter to fill the duodenum. Okay, and so you have also assisted procedure with single balloon or double balloon occluded gastroenterostomy. Like you see on this slide, you see the two balloon, and you see between the two balloons, the duodenum is filled with saline with methylene blue. Okay, so how to choose? We have a comparison between these two techniques, but not randomized, retrospective, and that shows that we have similar efficacy and success rate. and the direct technique was shorter than the balloon-assisted technique with comparable safety. And what is the practice, the current practice? Actually, about 2/3 of the cases are done with direct technique. So what is the interest of assisted technique? Maybe to better target the duodenum, and also maybe to stabilize a little bit better the duodenum. So we have a very recent meta-analysis, including 12 studies, and you see the direct technique was 68% of the current practice for EUS-guided GGA. So what are the main indications of the techniques? Afferent loop, gastric outlet obstruction, which is the main one, and altered anatomy. Just I show you the indication with afferent loop. You see this patient has a completely obstructed afferent loop, and you see because he had gastric carcinoma, this is the efferent loop, and so you see the afferent loop is filled with duodenal juice, bile, and pancreatic juice. And so we decided to do like for pseudocyst drainage, you see, direct approach with the LAMS stent, which was axial stent. And so you see the device is now deeply inserted inside the afferent loop, and we are going to retrieve the distal flange until we reach the jejunal wall. And now we are into the gastric remnant, and we are releasing the proximal flange until we have the bile flowing out. And this patient received again chemotherapy, and he survived more than 1 year. Okay. So we have the main series is had included 18 patients with technical success in 100% of the cases. You see, it's very easy to see the afferent loop, and the mean time was half an hour with clinical success in 88%, and adverse events mild to moderate in 16% of the cases. Now we move to gastric outlet obstruction. You have malignant indication and growing up benign obstruction for indication. So I just show you the comparison, only 2 studies. You will have all the studies in the ESG guidelines, but you see there's 2 main studies comparing retrospectively, and the technical and clinical success rate was similar compared to endoscopic stenting, but you had a higher reintervention rate with endoscopic stenting and comparable adverse events. You see the adverse events is about 10 to 15% of the cases. And comparing to surgery laparoscopic gastro GGA, and you see the technical success was less with GGA, but clinical success was the same with the same rate of adverse events. So I show you, I sorry for the title in French. You see it was patient operated for pancreaticoduodenectomy and recurrence, and you see the stomach was completely filled with retention, and you see the afferent loop, and you see we targeted the efferent loop, which was without any retention. And you see we push a 19 gauge needle inside the lumen of the jejunum, okay? And you see you have not to have the tip of the needle into the mucosa. And after you fill with saline and contrast until you fill completely the jejunum, you see now better the lumen of the jejunum, okay? And now you are sure you are in the jejunum, and you can push the gallois slightly and slowly until you push it far away. And after over the gallois, you push the Axios device. And you have to use pure cutting current and high power. I use at least 120 watts and pure cutting current, not undercut current, not coagulation current. If not, you have the risk of displacing the jejunum. And after, you release the distal and the proximal flange until you see the black ring, and you can release, you see the distal flange inside the jejunum, and you will see the proximal flange into the gastric wall. You see clearly the mucosa, and don't try to dilate or to do anything because you have the risk of displacing with the balloon the anastomotic jejunum. This is a direct technique. You see, usually this is half an hour. And use glucagon or hypokinetic drug to have no movement of the jejunum. This is very important, maybe the most important. Okay, now we move to benign obstruction. We have an increased rate of benign indications, about 15% actually. In our series, which is going to be published, it's about 40% of the cases with Crohn or chronic pancreatitis. And I show you there's two series. This one was published by Moine Kashab, comparing benign gastric outlet obstruction and malignant. And you see the technical success was the same. Clinical success was nearly the same, not different because there was only few patients. And reintervention rate was 11% of the cases, with a median follow-up of 131 days. And this very recent series published by James in GI endoscopy, and you see 22 patients with benign indication were included, 21 were successful, and the stent was removed in 18 patients with a request only in 5% of the cases. There were 3 adverse events, again 13% of adverse events, and surgery was prevented in 83% of the cases. So it could be considered as a bridge to surgery. I show you in a Crohn's disease, this patient underwent 7 resection of the small bowel, and he had again a complete stenosis of the duodenum. The surgeon told us do that endoscopically because we cannot do that surgically. And so you see again we push a 19 gauge needle inside the lumen of the duodenum, the angle between duodenum and jejunum. And you see we fill with solid and contrast, and after over the guide wire, we push gently the Axios device. Okay, now we are inside over the guide wire, and we are going to release the distal flange. Okay, and then you gently pull back the device until the distal flange is against the wall of the jejunum, and after you inflate the gastric lumen with CO2, and you see the black ring, and you can release the proximal flange, and the anastomosis is done. You will see, okay, we are going to release. Okay, now you release gently. Okay, so you pull back, but not too much because of the risk of dislodgement, and now you are in place, and don't do anything more. Okay, and you can check back the patient 1 week later. I show you. Okay, I show you the results. It was 1 month later, and you see due to the Crohn's disease already a kind of stenosis, but you can pass, and you see we saw a lot of ulcerations and stenosis in the downstream jejunum of this patient. Okay, and so we were able to treat this patient, and this patient now is okay. We have the full results, overall results in meta-analysis. I told you that 12 studies, about 300 patients, and the main indications was a gastric outlet obstruction in 2/3 of the cases, and the main technique was direct puncture technique, as I showed you in 2 videos, in 68% of the cases. And look to the technical success rate, 93, to clinical success rate, 90%, and adverse events, again, between 10 to 15%, it was 11% of the cases. Okay, so what are those adverse events? The rate is ranging between 10 to 12%, but you see the rate of severe or fatal complications is not weak, between 3 to 5%, about 3 to 5%. So take care, because you can have severe complications, mainly due to misdeployment of the stent, or dislodgement of the stent. So you have the distal flange into the peritoneal cavity. So you have to retrieve the stent and to close with OTSC clip. Or sometimes you have also a perforation of the jejunum, and this is a cause of peritonitis. So the rate for misdeployment or dislodgement is about 10% of the cases, requiring surgery in 11% of the cases. But you see, you can mostly manage it endoscopically with knots or with stent-in-stent technique, and this is the reason for why you need to have a guide wire inside the lumen of the jejunum. What about the patency? In this area of 45 patients, there was 2 recurrent obstruction. You see, one was early obstruction and one was late obstruction. What is the predictive factors for success of EUS-guided gastroenterology? This is, in this series, the distance between gastric and intestinal lumen. Now I move to the last indication, alternatomy. This is edge, and Geoffroy will speak about it in the afternoon. And you see, it was a patient with biliary jejunal anastomosis, and so it was not possible to access to the biliary anastomosis. So we decided to make anastomosis between the stomach and the jejunal loop, and you see we are doing with direct approach again, the anastomosis between the efferent loop. Okay, you see, of the anastomosis. And so we are making the gastrojejunal anastomosis, okay. And after you wait at least 1 week, because if you go as soon as through the stent, you have a risk of dislodgement of the stent, okay. So you see, we are sure we are into the loop. This is a clip of the surgery of the biliary jejunal anastomosis, and after we went 2 weeks later, and I just show you to start how I start this procedure. Okay, you see, we are 2 weeks later. Geoffroy will show you this video this afternoon, and you see you can pass throughout the stent without any risk of dislodgement, and after you go up to the biliary jejunal anastomosis very easily. And I show you another case with colojejunal anastomosis. It's not gastrojejunal, but colojejunal. It was a patient with pelvic metastatic obstruction. And so we went through the left colon, and we saw the dilated small bowel. So we were upstream to the obstruction. So we decided to do colojejunal anastomosis. And you see, it's always the same. You push your device, okay, you see the guide wire, and we are going to release, okay, the distal flange. And after you will go to the colonic lumen, okay, you see the release of the distal flange. And after we will release the proximal flange doing the colojejunal anastomosis. This is the release of the proximal flange. Okay, you see, and now you see the small bowel juice flowing into the colon in the colonic lumen. So you see no more occlusion, no more obstruction, and the patient was without any occlusion after that. And you can see the CT scan thereafter. You see. And you see, okay, you see here the anastomosis between the jejunum and the colon, and no more occlusion. Okay, so you can use this procedure for many things. Just 3 minutes to show you that you can do that only EUS guided. This is not procedure. We work a lot with Geoffroy for that, and we are doing an experimental study for doing bypass. For that, this is the small bowel after gastrostomy, and after we go inside the jejunum. You see, we are working with a double operating channel scope, okay, and we have a special grasper to hold the small bowel, and after we go back, we pull back to the gastrostomy. Okay, we release with the left operating channel, and we release the stent with the right operating channel, and you see clearly the small bowel. And I show you, because it is an experimental study, you see at 1 month you can go in the efferent or afferent loop without any problem. Okay, and you see after euthanasia it's very strong, and you see that tendency to fibrotic stenosis. Okay, we did that and we published that in human beings. You see, it was in 2015 with Candide Moller. Okay, and you see the CT scan 2 days after the first NOTS GGA. You see no complication, no hematoma, no leakage, and completely efficient. So I move to my conclusion. So LAMS gastrojejunal anastomosis are possible, mainly with EUS approach. And the main indication is gastric outlet obstruction. And the main approach is direct approach. Really, LAMS GGA are challenging duodenal stenting. But this procedure required experience and skillnet and should be improved for safety, mainly due to the mobility of the small bowel when you are doing the anastomosis. So thank you for your attention.
Thank you so much, Professor Barthet, for the amazing demonstrations of what is possible with EUS and creating all the different anastomoses. Now it is my honor to introduce Professor Mark Giovannini. He will be speaking on EUS staging of luminal cancer and subepithelial lesions. He is the chief of the department at Paolo Calmette Institute in Marseille.
Linda, I think that Mark Giovannini has got a problem to connect in, so I think we will move with Ankit Dalal, if you agree, and we will wait for Mark Giovannini after the lecture from Ankit, if you're okay.
That sounds wonderful.
Sure, that sounds good.
So Ankit,
yeah,
thank you for being with us.
Hello, Ankit.
Hi. Can you see my screen?
Yeah.
Yes.
Okay, so I'll just begin. So greetings from Mumbai. I want to congratulate the organizers of this conference. It's a wonderful, successful and educational conference. So I'll be talking about EUS guided drainage for pancreatic fluid collections and how to approach them. So go back to the revised Atlanta classification from 2012, and acute pancreatitis associated fluid collections can be either related to interstitial pancreatitis or necrotic pancreatitis, and they are classified within 4 weeks as acute peripancreatic collections or acute necrotic collections, which then get organized subsequently to form either a pseudocyst or a walled off necrosis. And when these become symptomatic with either infection or obstructive symptoms to either the lumen or the biliary tract, they require drainage. Endoscopic drainage has been attempted for these peripancreatic collections since the 1980s when EUS was not there, and at that point direct endoscopic drainage was done depending on the bulge that you could see within the GI lumen. But since the advent of EUS, it has taken over all the drainage procedures. And that's why. Why do we use EUS for drainage of peripancreatic collection? Firstly, because it can identify and distinguish the lesion even if it does not bulge into the gastric lumen. And with the help of real-time imaging, we can visualize the puncture needle lengthwise during the process of puncturing. Also, EUS is accurate.
Ankit,
Yes?
Ankit, can you move closer to the microphone because we cannot hear you very well?
Can you hear me now?
Yeah, much better.
Okay, sorry. So EUS is also good in in quantifying the solid debris within the collections. So it's better than contrast enhanced CT, and it's comparable and better than MRI to quantify the solid debris. So that helps us in maybe deciding the stent choice for drainage of these collections. and the help of color Doppler can help us avoid the intervening blood vessels. So EUS is reliable and safer than direct endoscopic methods. A couple of RCTs which were done in in 2008 and 2009, which showed that EUS guided drainage was much better than direct endoscopic drainage with better efficacy and lower complications. Timing of intervention. So this is one of the most important aspect. When do we intervene? So the literature unanimously says that you should intervene when symptomatic collections after 4 weeks of the onset of acute pancreatitis to minimize any morbidity and mortality which is associated with early interventions. The collections are well encapsulated, and it is logical to delay drainage as much as possible because the solid debris within a walled off necrosis tend to liquefy over time. But recently, in the last couple of years, certain centers, high volume tertiary centers, have attempted drainage of these peripancreatic collections between 2 to 4 weeks after the onset of acute pancreatitis, especially in symptomatic patients with infection. And the studies showed that the drainage in early phase is safe and efficacious, although they are associated with a higher morbidity and a higher likelihood of reinterventions and also surgical interventions. So presently, I think early drainage should be limited to centers that have a high volume, tertiary centers with good experience and a multidisciplinary team available to manage any complications. So when do we treat these collections? So as I said, either they are symptomatic with obstructive symptoms to the lumen or the biliary tract, or they are infectious. And when we look at pseudocysts, most of these pseudocysts can be treated with drainage alone, and the success rate for that is more than 90%. Whereas for walled off necrosis, drainage alone is only satisfactory in about 60 to 70%, and often aggressive therapies are required. These are nasocystic drainage or irrigation, endoscopic necrosectomy, and there are multiple different approaches which have been described for complicated walled off necrosis, which is the multiple transluminal gateway technique described by Vardarajalu group, wherein you make multiple access routes to the collection and place multiple plastic stents. Also, there is the dual modality drainage and the hybrid endoscopic drainage, which combine percutaneous as well as endoscopic approach to drain the walled off necrosis. What is the basic technique of doing EUS guided transmural drainage? Antibiotics for all patients. We first confirm the indication, whether the lesion is well walled off and has a decent lumen. Assess the relationship of the collection with the GI lumen. And then we go ahead with the puncture. We use a 19 gauge needle. The site of the puncture could be either the stomach or the duodenum or esophagus in certain cases. We have to be sure about this because sometimes when the collection is located near the anterior wall, there can be a possible risk of free perforation. Whereas the posterior wall of the stomach near the lesser sac, that risk is negligible. Following the puncture, aspirate some of the fluid. You can send it for analysis and then subsequently place the guide wire within this cavity with enough coils. So basically, this is the last chance before you can before you can abort the procedure. Once you create the fistula in the next step, there is no going back. So this step is then followed by the tract dilation, which can be used, which can be done using a 6 French cystotome, which we use regularly, or a needle knife or a balloon dilator. And then following which you can place a plastic or a metal stent, or you can place a nasocystic drainage tube. The stents which are available for drainage of pancreatic fluid collection. So you have plastic stents, which are your typical double pigtail plastic stents, 7 French or 10 French. These stents have low risk of migration, they are easy to remove, and they are inexpensive. But due to their smaller diameter, they have an increased risk of occlusion with secondary infections, more frequent reinterventions required, and for drainage, they are more challenging, they're time consuming, and repeated sessions may be required. Alternatively, metal stents have been introduced. Earlier, we used the fully covered metal stents, the tubular stents, but they were also associated with higher rates of migration. And so dedicated stents for EUS guided drainage, which had a biflanged wide lumen design, like the biflanged metal stent, which is the Nagi stent, or the lumen opposing metal stents, which is the Axios and the Spaxus, were developed. The advantages of these stents that they had a good tissue apposition power, so they had a lower risk of migration, there is lower risk of leakage, and because of the larger diameter, there is improved drainage with necrotic debris within, and it served as a port for performing direct endoscopic necrosectomy. Now, all of these stents now come with an electrocautery enabled catheter, so the insertion and deployment of the stent is much simpler. These are a couple of videos of drainage of pseudocyst using a plastic stent and with a hot axios. Here on the left, we have a large collection, a pseudocyst, which is punctured with a 19-gauge needle, following which a guide wire is inserted, and then the tract is dilated using a balloon. And once adequate dilation has been obtained, you can place a double pigtail plastic stent for drainage. On the right, similarly, we have a large collection which is causing a bulge into the GI lumen. And on EUS, we can see it's a large pseudocyst with clear contents. And we proceed by deploying a electrocautery enhanced hot axios. Here we have entered into the cyst cavity and we are deploying the distal flange and pulling the stent to closer to the cyst wall, and then deploying the proximal flange under endoscopic guidance, and we can see the gush of fluid that happens once the stent has been deployed. So the question remains, which stent is appropriate and when to use which particular stent. So the data has been unfortunately quite heterogeneous. Most of the studies are retrospective in nature. Very few randomized trials are available. So it's still a debate which is the ideal stent for drainage. As far as pseudocysts are concerned, double pigtail plastic stents achieve a good drainage, a good success. You have nearly 85 to 95% success to drain pseudocysts using double pigtail plastic stents. There are a couple of recent studies which did a direct comparison between LAMS and double pigtail plastic stents for pseudocysts. Both of them were retrospective in nature, but they found that the LAMS had greater clinical success with lower adverse events and lower rates of recurrence. Similarly, the other study also found decreased risk of reintervention with usage of LAMS. When we look at comparison between the two types of stents for walled-off necrosis, I think the data tends to be more favorable in the favor of LAMS. So several studies which have evaluated this, again, most of these are retrospective in nature, but these studies have found that the success rate and the requirement of reinterventions is much lesser with the LAMS. The success rate is much better with the LAMS group. Even the adverse events which have occurred in the LAMS were lesser than compared to plastic stents. LAMS require shorter procedural time with fewer requirement of surgery. So LAMS definitely is preferable with the studies with respect to walled-off necrosis. But as I said, most of these studies are retrospective in nature, and there are very few RCTs or prospective studies which have evaluated both the stents. And one study by Bang from the Sham Vardarajalu group, they did a RCT for drainage of walled-off necrosis and compared LAMS to plastic stents. And for them, there was no difference in the clinical success between both the stent groups. Even the adverse events were although they were higher in the LAMS group, they were comparable. But the other studies, like the one couple of studies which were done from our center, which were prospective in nature and which evaluated the Nagi stent for drainage of walled-off necrosis or pseudocysts, we had a great clinical as well as technical success rate with few adverse events. So most of the meta-analysis and systemic reviews tend to favor LAMS in terms of success in terms of drainage, also the requirement of re-interventions, and fewer necrosectomy sessions with LAMPs. Except for one meta-analysis which showed comparable success with the LAMPs as well as the pigtail stents. So we are still in need of more robust data, more RCTs to give us a clearer idea as to which stent would be preferred in the situation. And I think a couple of RCTs are underway and we are awaiting the results for the same. LAMs are not without their complications. So several complications can be attributed to LAMs. The most commonly one is bleeding, which we can see here. This is a patient that we had drained using an Axios, which came back with massive upper GI bleed, as we can see here. And EUS at that same point showed that there was a blood vessel which was abutting close to the LAMs, which was possibly a pseudoaneurysm. So this patient was shifted to the cath lab, and we found on angiography a pseudoaneurysm which was successfully coiled and the bleeding was controlled. The second most common complication that can happen with these metal stents is dislodgement, especially when we are trying to do necrosectomy. You can inadvertently hold on to the metal stent and it can get dislodged into the GI lumen. Migration of the LAMs is less commonly seen, but here we have a case wherein the stent had migrated into the GI wall, which we can see here on EUS, the pseudocyst and the LAMs, which has migrated into the GI wall. Very rarely, you can encounter this complication of buried LAMs, wherein there is ingrowth of the gastric or the duodenal wall, which leads to complete disappearance of the LAMs in the lumen. And we have to try to retrieve this using sometimes a needle knife or just under fluoroscopy guidance to grab the LAMs using a rat tooth forceps and trying to pull it out. So these are certain of the complications that you can encounter with LAMs which need to be addressed. So there are several ways where we can minimize these adverse events caused by LAMs. One of them is modifying the stent design to have less irritating tip of the stent which can avoid bleeding, to have moderate apposition power so this buried stent syndrome can be reduced. Use of PPIs perhaps may benefit in bleeding by increasing the gastric pH, but that's uncertain. Having a large diameter stent to allow easy passage of accessories for performing necrosectomy, especially in large wounds with large amount of debris, will be helpful in avoiding stent occlusion and dislodgement. This definitely is helpful when we can place a double pigtail plastic stent through the LAMs, which can avoid stent occlusion and bleeding. This has been well documented and is practiced in several centers. And early follow-up and stent removal is recommended. So for a walled off necrosis, removal of the metal stent by 3 to 4 weeks after confirming resolution, or removing after 2 weeks in cases of pseudocyst with complete resolution. So it's important to remove this metal stents early. What is the indication of necrosectomy? Patients who have undergone drainage and now come back with infected necrosis. These are the typical patients who require necrosectomy. They need to have a mature wall, perform this necrosectomy under CO2. So this is a patient who we had placed a Nagi stent, and after placement of the Nagi stent, he came back to us with fever within a couple of weeks. And here we can see that there is a large amount of debris which is occluding the stent, causing infection. So we went ahead and performed necrosectomy, and you can see the gush of pus that came out once the debris was dislodged. So using a combination of irrigation with hydrogen peroxide and then using snares, baskets to perform the necrosectomy, we are able to clear out the debris. And the end point of necrosectomy would be to have a clean cyst wall, which has pink granulation tissue like this, what we see here, which it signifies almost complete clearance of all the debris from the world of necrosis. So a step-up approach for necrosectomy is routinely recommended after placing a metallic stent. So in cases where there is no improvement after placing the metallic stent, the first step would be to assess and declog the stent if required, if the lumen of the lamps is blocked. Second, you can place a nasocystic tube and go ahead with irrigation or perform endoscopic necrosectomy if required. The Asian consensus also states the same thing, that after drainage of a walled off necrosis with a metal stent, if there is incomplete resolution, we can go ahead with performing endoscopic necrosectomy if necessary. And surgery is recommended only when these steps fail. There has been one study which compared initial or early direct endoscopic necrosectomy with late endoscopic necrosectomy, and the success rates were equal between both the approaches. The requirement of necrosectomy sessions were much lesser in the initial group compared to the later group. So this needs to be further evaluated if early necrosectomy is more beneficial. Finally, when we have to deal with this syndrome of the disconnected pancreatic duct in patients who have peripancreatic collections, because patients with this syndrome tend to have recurrences, which may require a different strategy for treatment. So this was again studied in our department, and we had published in Endoscopy 2018, where we evaluated patients using a dynamic secretin enhanced MRCP. And the treatment approaches for patients who have a complete disruption is to place a long-term plastic stent in the cavity, which leads to a low recurrence. Or if it has been drained using a LAMS, remove the LAMS after 3 to 4 weeks and replace with a plastic stent. In cases with a partial disruption, wherein there is a pancreatic ductal leak, you can attempt placing a transpapillary pancreatic ductal stent to bridge the disruption, which can help reduce the recurrence rate. This published recently was a large series of patients with walled off necrosis who had undergone drainage with Nagi stent with a median follow-up of 30 months, and the stents were removed at 4 to 6 weeks, and the pancreatic ductal anatomy was evaluated using MRCP or ERCP, and they found disconnected pancreatic duct in nearly 2/3 of the patient, with PD leaks, strictures, and calculi in the rest. But out of all these patients, only 34 patients had developed a recurrent pancreatic fluid collection. And the risk of this recurrent pancreatic fluid collection was much higher in patients with a disconnected pancreatic duct. And reinterventions were required in only 17 patients who had symptomatic recurrences. So recurrences of pancreatic fluid collections are negligible in the absence of a disconnected pancreatic duct. Most of the recurrences are asymptomatic and can be observed. And the idea should be to treat the small number of symptomatic recurrences as and when required. So finally, if you look at an algorithmic approach towards a symptomatic pancreatic fluid collection, evaluate it if endoscopic drainage is feasible. You have a pseudocyst or a walled off necrosis. For a pseudocyst, you can place single or multiple plastic stents, or secondarily, you can place a LAMS as well. For a walled off necrosis, a LAMS or a biflanged metal stent is preferable, or place multiple plastic stents. For walled off necrosis, if you don't have clinical response with drainage alone, proceed ahead with either nasocystic tube drainage or performing endoscopic necrosectomy. Once you have clinical response in both the groups, you can assess for the PD integrity by using MRCP. If there is a leak and if you can bridge the leak with ERCP, place a plastic stent. If not, plan the cystogastrostomy stent removal after resolution of the PFC by say 3 to 4 weeks. Follow up the patients and place plastic stents in patients who have recurrence secondary to a disconnected pancreatic duct syndrome. So in summary, EUS guided pancreatic fluid drainage is the preferred route for drainage when feasible. Plastic stents or LAMS are equally good for pseudocysts. For walled off necrosis, LAMS seems to be better. Plan LAMS removal by 3 to 4 weeks to avoid unnecessary complications. perform necrosectomy as a step-up approach, and evaluate for disconnected pancreatic duct syndrome and consider pancreatic ductal stenting where appropriate. Thank you.
Thank you very much, Professor Dalal, for that wonderful presentation. I think at this point, we're going to go into actually a little bit of question and answer time because Professor Giovannini is still having some issues connecting. So hopefully, really hoping he'll be able to get on. So there are lots of questions about these various techniques. And I just want to ask you first, Ankit, so in terms of your approach then for walled-off necrosis, do you just typically place a LAMS and don't do necrosectomy the first time, watch the patient, and then only if, you know, they have fevers, they're not doing well, responding, then go in to try to do necrosectomy? And associated with that, do you, at the time of placing LAMS, routinely place a double pigtail stent through the LAMS in the hopes that it might prevent some of the necrotic debris from clogging it up?
Yes, so typically all walled-off necrosis which are drained with LAMS, we place a double pigtail stent through the LAMS to avoid stent occlusion and subdurable. And we perform necrosectomy if the patient is symptomatic. The patient comes with fever or...
I'm sorry, it's a little hard to hear you. Can you get closer to the
I'm sorry. I don't know what's wrong with my microphone. Yes, so we place double pigtail stents routinely through a LAMS at the index procedure. And we call the patients for necrosectomy when they are symptomatic. If the patient develops any fever or increasing pain abdomen, is when we perform.
Ankit, could you be close to your microphone because we cannot hear your answer.
Is this better now?
Yes.
Yeah, much better.
Okay, so we place the double pigtail plastic stents routinely at the index procedure through the LAMS, and we would do the necrosectomy if and when the patient becomes symptomatic with fever or increasing pain abdomen.
And do you, there's a question about, I know you mentioned in your talk use of hydrogen peroxide, so maybe you can comment on that. I know there's a recent study from a US group about that. And also if you've had any experience using the endorotor to try to break up the necrotic debris.
I haven't had any experience using the endorotor, but yes, we do use hydrogen peroxide for irrigation during necrosectomy. Yes, hydrogen peroxide we do use in our department regularly while performing necrosectomy.
Mm-hmm. And can you tell us kind of, you know, how much of it you use and how you, you know, prepare it?
So we dilute it. We use about 20 ml of hydrogen peroxide in 500 ml of normal saline.
Okay.
And we use that for irrigation.
Okay. And Professor Barthay, I was wondering if you could comment a little bit about the learning curve for learning EUS guided gastrojejunostomy, and also kind of within the whole gamut of what we're able to do now in therapeutic EUS. You know, is that something that, you know, somebody who's starting out should, you know, avoid doing at the beginning, maybe start with necrosectomies? Like, what is your kind of approach to people learning?
We start to have some information about the learning curve from gastroenterostomosis. I have to say that, of course, you have to be experienced in therapeutic endoscopy and in therapeutic EUS, because I think it's not so difficult, but you can have huge complications. And the main complication is misdeployment or dislodgement. Also, you have to be able to face to any digestive perforation. And as you saw, the rate of dislodgement is ranging between 10 to 20%. I'm just putting my case with Moen Kashab, and we are going to publish it and to present in AGA. So the rate is nearly about 20%. So it's not, it's a lot in fact. Okay, and I think it was underestimated in meta-analysis and in multi-center series. So we have to take care because we have still the problem of the motility of the small bowel. And so this is the reason for why I told you use hypokinetic drug or glucagon because it's very efficient, and I use usually 3 doses of glucagon during my DGA. The learning curve actually is estimated about 25 cases. 25 cases, okay? But 25 cases for people doing already therapeutic EUS. So as you know, for doing therapeutic EUS, you have to start with pseudocyst drainage, and after biliary drainage, after pancreatic ductal drainage, and after gastroenterostomosis. This is a way to try to have the more success and the less complication. But even in the hands of experts, you can have misdeployment or dislodgement. So I had this complication during a video meeting, so in Belgium. So I can remember it, and I was very happy with my procedure, but finally I had a dislodgement. So you have to take care, because even if you're an expert, you can have this kind of complication, and you have to know how you can solve this problem. And the way to solve this problem, if you have any dislodgement, if it is a dislodgement of the small bowel from the stomach, it's very easy, because usually you take back the stent and you close the stomach with OTSA clip, and it's sufficient. And you have to follow the patient to be sure you have no peritonitis. If it is a dislodgement of the stent from the gastric side, which is very infrequent, it's a real problem, because you have the stent open into the small bowel wall, and so you have always peritonitis. So if it is this case, go to the surgery, because you cannot solve the problem endoscopically.
The learning curve you present of 25 cases, which was published recently, it is a learning curve, but for only experts operator finally.
Yes.
It means our learning curve, but I think that it will be
I agree.
in the most.
I agree. It's not only a question of learning curve in experts hands, but also in expert centers. And so, because in expert centers, you have the experience how to face in case of huge problem, and this is a very important problem. So you have not only to be alone, you have to have other experts with you in case of problem, and also a surgical team, because you see about 11% of the cases require surgery. So you have also to have a good surgical team, not fighting with them, because we are complementary. Okay, but I agree with you. This is not the most difficult procedure, because some hepatic ulcerostomy are more difficult, but it's the most risky procedure, because if you have any complication, you saw the rate of severe and fatal complication about 5% of the cases. So it's a huge problem. So take care.
Professor, how do you compare this with standard duodenal stenting for gastric outlet obstruction?
Sorry, Ankil, how do you compare?
Standard enteral stenting with gastrojejunal anastomosis for gastric outlet.
Okay. Yes. It's a good question, and we have only a retrospective comparison in the literature. We need to have a randomized series. Actually, in my department, I'm moving more and more to direct EUS guided gastroenterostomosis, because on a functional point of view, it seems to be more efficient. And secondly, you need less reintervention. This is clear in the literature. You need less reintervention, but also for me and to my first assessment, it seems to be more functional EUS guided gastroenterostomosis than duodenal stenting.
And Professor Dalal, there were a couple of audience questions about techniques. One was, why don't you use the 10 French cystotome without balloon dilation? And another one is, how do you judge that the cyst will not shift away, move away from the gastric wall, when you're doing the cystgastroscopy or necrosectomy?
So 10 French cystotome, I think there are a couple of people who have used a freehand 10 French cystotome to puncture the cyst and then place the stent. You can use it, a 10 French cystotome, but we don't use it. We usually puncture which place a 6 French cystotome and then dilate up to with a balloon catheter and then place the stent. With respect to the cyst wall moving away with the lamps, because of the apposition power of the lamps, it's very rare.
I'm sorry, Ankit, it's a little hard to hear you again. If you could get a little close. Thank you.
So while doing necrosectomy, especially when you have lamps in place, the fistula tract has well created, and because of the presence of the lamps, it is unlikely for the cyst wall to move away when you are doing necrosectomy using your standard gastroscopes. And for a 10 French cystotome, yes, you can use a 10 French cystotome to puncture the cyst. It has been described by a center in India and it has been published, and it is found to be safe. So you can use a 10 French cystotome to puncture and then drain the cyst using a stent.
And maybe it is a question of cost also.
Yeah.
Also.
Mm-hmm.
Okay, just Linda and Geoffroy, I was told that Mostafa Ibrahim is ready. And so if you agree, we can move to Mostafa and then we can go back to go on with the discussion. You're okay?
Sounds perfect.
Thank you. Mostafa?
Okay, you can hear me and you can see me?
Yes.
Yes.
Okay,
Mostafa, you look so smart.
Thank you. Thank you. Okay, so first of all, again, thank you all for being with us. So really, it's a great honor to have the second day of EUS Days. So today it's a new concept. We started. So the concept of EUS Days, when myself and Professor Barthe thought about it 4 years ago, it was to have always theoretical lectures and pure hands-on training. And this is what we have done together in Dubai and then in Thailand. And hopefully we'll do it again next year when travel restriction is off. But today, to have the same taste of the same idea, to have part of the hands-on lectures. So today what I'm going to do for the next 20 minutes a session of hands-on training, a virtual one. So what I'm going to do, it's really going to the basics. So what I'm going to do how really to do correct FNA, FNB, and then how to do put a lamps and axial stent in a cystic lesion. I'm using both Roya models for both of them. I'm using today a linear EUS scope from Fujifilm. So as you all know, a linear EUS scope, which means that you have the probe on the lateral side, and then you have the working channel, same like the ERCP. So step by step, to be able to do a correct FMB, number one, you need to detect the lesion. So I will start my examination here. If you can have the EOS image. So this is one of the models that you can have. We have already simulated some lesions. So for example, this is a very clear hypoechoic rounded lesion. So my target is to do a correct FMB from this lesion. So what should I do? Number one, you should be always touching or very close to the mucosa. So I'm doing a little bit of up to always touch the mucosa. Number two is suction. So having suction to make sure that you don't have any air interface. Number three, I'm going to put my needle. So I'm using, as I said, 22 22 gauge FMB needle, acquired needle from Boston Scientific. Just to explain a little bit about the needle itself. So this is so the needle you have, this is the typical FNA FMB needle, which you have few things to explain. Number one, you have the first wheel. This controls the movement of the external sheath. So when you open this and you push and you pull back, you control the length of the external sheath out of the scope. And then you have, secondly, the other one, which is you control, this is the second wheel, where you control, if you zoom a little bit on my hand, here where you control the needle itself. So that the needle in and out. And if you can see on my left hand, that I control the movement of the needle by my left hand. So to put this one, when you are in a patient, and this is what I always tell to my colleagues and younger fellows, if you really would like to start very basic, you need to measure, if you can have the EUS scope again. So you need to measure from here till here how many centimeters, and then you need to block the needle, let's say about the same centimeter. This is the idea that when I push my needle, not to have the needle out beyond the lesion. This is, I would say, this is the very safety basic steps. On the other side, when you are more advanced, you can simply put your finger here. And then when I will do this maneuver, my finger is my guidance to stop. So sometimes I will push my finger a little bit down, which means I would like to go inside more. I will put my finger and I control my movement by my other two fingers. Last point before I go to the model is the stylet. So we have this stylet inside the needle, and what we do always when we start puncturing the lesion, we will pull back, and this is what I learned from all the big experts. We pull back the stylet 1 centimeter back, and the idea is to have the tip of the needle very sharp to be able to go inside the lesion. After that, I will push it back to make sure that this very small amount of tissue inside the needle is out, and then I will start my forward and backward movement inside the lesion. What we do, we have two types of having negative suction inside the needle. Either Salma will start pulling very slowly the stylet just to create negative suction inside the needle, and this is how we acquire the tissue. Or the other scenario, we can just pull this and put the negative suction syringe. This is what I'm going to do now. So back to the EUS image again. I will increase the gain a little bit. You can see now this is the targeted lesion. So my target is to take an FMB from here. So what I'm going to put, I will close my elevator, putting the elevator down, and I will put my needle. So all the ES needle are a standard length. So you just push it till you fix it here. So this is number one. I will fix it in the scope like this. So now it's fixed. And then I will open a little bit my elevator and start just pushing first few centimeters of the external sheath. You can see here on the model, this is the external sheath of the needle. I will even, sometimes I would like to pull it back few millimeters, just not to have a lot of the sheath outside. This will have a kink on the needle itself, and it will make your life more difficult. So now I have only 1 centimeter of the sheath outside. Second, I will open the second wheel to be ready for the pushing of the needle. I will pull back the stylet, as I said, this 1 centimeter, and then you can see by the elevator you can really direct. So the needle is coming, and I'm inside the lesion. So now my needle is here. So everything is really under EUS guidance. And then I will start pulling back and pushing to start having the tissue. Meantime, Salma will start pulling the stylet very slowly, and this will create the negative suction. Sometimes, if you also to show you how to do this fanning technique, and the idea of fanning that I need to redirect my needle inside the lesion. So you can do this by two techniques, either by elevator, and sometimes also by the big wheel. So now, for example, I'm now changing a little bit of down, and I'm moving my needle inside, so I can take, every time I come back, I will change. So I'm taking from here now. You can see this is the typical fanning that you can take from different sides of the lesion. And then so just to show you the other thing, I will pull back now the stylet totally, and you need to connect the negative suction. So two very important technical tips for connection of the negative suction. Salma is the best nurse, I think, in the Middle East. But you need, when you work with really nurses that they are start of working with you, you need to double check that they have negative suction. So I will ask Salma to show you how to make sure. So you need to push the air out, and then close the valve and create the negative suction inside. Now I am sure that I have negative suction. Another the very technical tips when you are doing the patients, sometimes I will take the syringe myself to put it, and while I'm pushing my needle. So I fix here my needle, and then I will ask Selma to connect the syringe, and I'm fixing my needle to make sure I'm not pushing the tip of the needle outside of the lesion. I will ask Selma to open the negative suction. And you can see even here on the image here, a little bit of air, which is typical of the negative suction. So I'm doing again my my fanning, changing the direction of the needle. And sometimes when like this, when you see that you don't see anything, you stop. And then you adjust your position I remember very well, Pierre, years ago when I was in Brussels, told me always EUS is a very, very fine movement. So there is nothing really, it's a few millimeter movement. And I will just remove this arrow. I will continue taking my F&B. And then when I'm finished, very important, you stop, you close the negative suction to make sure not to aspirate from the gastric mucosa. And then I will fix my needle again. I will ask Selma to remove the syringe. And then I will pull back first my needle inside the sheath. I will block the first wheel. And then I will open the elevator, pull back the second wheel of the sheath, close the elevator, close the second wheel, the second lock, and then I will take the needle out. And then I will show you now how we normally put the tissue outside. So if the camera can just focus here, we will do this. Yes, I will leave the scope for a second. And now what we do, 1 second, I will just bring one of the white things to make my life easy. Yes, like this. So what I'm going to do now, normally when we are going to push the material here on the slides, I will ask Selma first to push the needle out for 1 or 2 centimeters. Yes, like this. And then Selma will start pushing. You can see, yes, very good. She will push the stylus outside. Yes, yes. She will continue pushing the stylus. Okay. And then after that, she will remove. You can make it on the blue. There is white material, but we can make it on the blue. She will push now with the syringe. Yes, push with the syringe. Air, yes. If you can focus here, yes, very good. Push with the syringe. Yes, if you can, yes, you can see, yes, you can. You can see there is whitish material which we got it from inside the lesion. So now this is the typical how we do it. So I will ask Salma to pull back the needle, and normally in the real life we will repeat this procedure 2 or 3 times. As I said yesterday in the live case, I always do this under with one of the pathologist friends who is a rose technique, to have always on site someone to tell me, okay, Mustafa, we have enough material for the pathology. Second, for the next 10 minutes, I will show you the other technique, which is inserting an Axios stent inside. You can see now this is another model showing a typical infected pseudocyst or a ward of necrosis. You can see a very a cystic lesion here with a lot of necrotic material inside, and my aim is to put an Axios here. So the Axios, as you all know, we are using the hot Axios stent. It's a one-step technique. I'm using now also as an electrosurgical unit. I'm using the BUVA machine, the ARC 350. So what we are going to do, same technique. We identify my cystic lesion. I sometimes I use just the guidance to understand where my stent will be coming. Also, the hot Axios stent the length of the hot Axios stent is compatible with any EUS scope. So you don't bother yourself of adjusting anything. You just push it till the end, and then you fix the stent here. So this is number one. So if you can focus on my hand for a couple of seconds, we have here everything really enumerated. So you have 1, 2, 3, 4 steps. So step number one is we will be from here is to push the needle itself with the current to puncture the lesion. This is number one. So I have here unlock and unlock. First of all, I will unlock it. I will puncture. After that, I will lock it again, and then I will release the distal flange of the stent inside the lesion, pulling back everything inside the working channel, and then finally releasing the proximal flange. So please, if you can have the EUS again. So first of all, I will just push. I will remove this a little bit. I will push my needle. You can see it coming. It's here. I will do a little bit of suction. I will adjust my position, increase the depth a little bit. Suction شغال. Okay. Yes, you can see it now. So I will pull. Wait a little bit. So very important to take your time to make sure that you are in the correct position. Okay. Also, what we have here, we have we have also one of our new cameras. It's a cooperation between us and Philips. We have another camera which will be really launched very soon on our models, which mimic the X-ray. So I will ask just to put the X-ray machine, the X-ray image for 1 second, please, for the control room. Yes. Oh. Yes, on the tip of the tip of the scope. Yes. And see, this is the needle. Stop. Okay. This is just to show you that this is I will do it under EUS control, but just to show you that you can do it. Stop the camera. Okay. So now I'm just adjusting my position to make sure. ممكن تمسكي سلمى المنظار. Okay, like this. And now I will puncture like here with the current. Okay, I punctured. I will show you just one more second of this X-ray. So X-ray, please. You can see. So I already stop. I already punctured the cystic lesion, and now yes. Yes, and I opened the first flange. Okay, and then next step will be I disconnected my electrosurgical unit. Could you have my hand, please? Okay. Next step it will be to yes. Could you have the X-ray with my? Could you put my hand as a small image and the X-ray image as a big one? Okay. Yes. X-ray on. X-ray on. Okay. I am pulling back my distal flange, as you can see now, releasing the stent, pulling back my needle a little bit like this. Yes, like this. Yes. So this is the typical thing. So you have, okay, stop. So you have the distal flange inside the collection and the proximal flange outside in the lumen of the stomach. And this is just I would like, so you need, for example, this is very important message here, and then I will leave the discussion for Professor Barthe and all the experts. So it seems that it's an easy technique. Yes, it's easy. You need a learning curve, and this is why even Boston Scientific will never accept that you can use the hot axis before being learned on a simulator, and then few cases under supervision before you are ready to go. So, but I think this is one of the very easy technique to be done. There is another technique that you can use it, the ordinary one, which is puncturing the lesion with a 19 gauge needle, putting a guide wire, and then exchanging the guide wire with the stent on the guide wire, and then doing what I have done. Sometimes normally we can use, this is what I call a freehand technique. In a very big collection, you don't need really any guide wire. On the other side, and in difficult position, I prefer to put sometimes the 19 gauge needle, a guide wire, and do the exchange over the stent. So this was on a very short, in 20 minutes, showing you really what we can do for the two techniques, let's say two daily techniques, FMB and fluid collection drainage. And if there is any comments, I'm ready to answer.
Thank you, Mustafa, to be always very didactic and precise in your explanation. You always use a smear
I cannot.
to obtain your sample, or did you think that there is always a place for it, or because in my practice, in my daily practice, I put all in citolate, and I forgot to perform smear from so many years. So what do you think about that?
Mustafa?
Mustafa?
Here,
You hear? You hear the question of Geoffroy? Mustafa, you hear us? No?
I don't.
No.
Yes, could you repeat the question? I cannot hear.
Do you?
Yes, I can hear you now.
Okay, perfect. Do you always use smear for your sample receipt, or did you? Because for me, in my daily practice, for many years, I put all the sample in the citolate. What do you think about that?
Okay. This is very important question. So I'm just blessed to have one of my team, the pathologist, with me always in the FMB. Sometimes in hospitals where I don't have an on-site pathologist with me, no, I will put it in citolate and then I will send it for cytology. Personally, I prefer to have someone with me, not for diagnosis, however, for just to confirm on me that he has enough material for diagnosis.
Yeah, Mustafa, this is we will take the advice of Linda, and after from Ankit. But this is a very important question, because in the literature there is a great confusion between the accuracy of FNI or FNB and the quality of the sample, which can be studied and assessed by the pathologist. And we have to do the difference. And I fully agree with you. rapid on-site evaluation is not useful for be sure about the diagnosis, but be sure about the quality of specimen you catch with your needle. In France, I don't know in USA, but or in India, but in France, it's not possible to have a pathologist on-site evaluation. We have not so more pathologists available, even when they are at their desk and at a microscope. So in our endoscopic room, it's clearly impossible. So we have to check by ourselves how to know if you have a good sample or not. And usually I look in my bottle if I have a white piece and not a red piece, because the red piece is blood, and the white piece. And if I have a sufficient white piece, I say we stop the sampling. So Linda and Ankit, what do you think about it?
Yeah, I mean, I personally agree with you. I mean, we actually did a randomized study. This is a while ago now. It was a non-inferiority study comparing, now this is FNA, so before FMB, FNA with rows and FNA without rows. And and the arm with FNA without rows, we actually did 7 passes into pancreatic masses, and found that it was not inferior in terms of the diagnostic yield. And, you know, obviously with FMB, things have changed now, and I think it's even better. So we do have the ability to call our cytologists into the room. We don't, because it just takes so much time. Even if we call them, like, you know, before we start the EUS and give them a heads up, I mean, it just takes them so much time to come, and it's just not practical for us to do for all of our cases. So in all honesty, we don't routinely use rows, and we do exactly what you mentioned, which is to assess the quality. We're looking at the bottle, making sure we see enough of those white pieces. And if we don't, you know, then obviously we try to do more FMB samples. And that's really our current practice.
I have a comment for you, Professor Linda, but because this is very important on even our daily practice. What both of you, Professor Mark Barthé, also do when you have this situation, because this is, I see it a lot when I was, especially maybe not in Brussels, when I started back here in Egypt, that when you do the procedure and without having the pathologist on site, and then you have, after a couple of days, the patient coming to your clinic with the pathology report saying, okay, doctor, this is the pathology report, and the report is okay, we have a little bit of atypical cells without really a conclusive diagnosis. So what you do really in this clinical difficult condition, you will repeat again FMB, because sometimes we do as you said and as Mark said, and then the pathology will come, the cytology will come, okay, we have some atypia there and here, but we don't have really very enough cells to have all the immunohistochemistry testing and all of this. What we should do in this situation?
I mean, I think that's a great question. And obviously, you know, I think we all encounter that kind of situation. You know, some people just don't have access to on-site pathology. And I think in that case, I mean, one thing that seems reasonable to do is potentially repeat the EUS. And if you did not use elastography or contrast harmonic EUS, perhaps use that to see if that can guide you in terms of where to do the FMB or FNA. That might be helpful. If you do have rows available, then I think certainly it's reasonable during that second EUS to have the pathologist in the room to guide you, so that you don't come up with a second non-diagnostic EUS.
Yes, I would agree. I mean, we don't have on-site pathology in our center. So we, as Professor Barthé and Professor Lee said, we would look at macroscopically if the tissue is adequate. And in case a patient comes back with a negative report with a high clinical suspicion, in certain situations, yes, we would then request the cytopathologist to be on site to then perhaps have a diagnosis in a negative FMB.
And there's a question here, I think, from the audience, Mustafa, where they're asking about what do you think about choosing among the different FMB needles rather than going with FNA?
Yeah, so should I, if I understand correctly, should I go always with an FMB needle rather than FNA? Yes, this is the question, yes?
Yes, I think that's what they're trying to
No,
ask.
what I will do if I have a solid lesion, I will go always with an FMB needle, not only for having a good quality of my specimen, but also nowadays there is no oncologist will start treating a malignant patient without having all the immunohistochemistry on the specimen, really to have this targeted therapy nowadays. And to have this targeted therapy, our cytologists and pathologists, they really need tissue. So for region, if I will choose, I will choose always an FMB needle. This is number one. On the other side, if it's a cystic lesion, I don't see that there is, and I would like just to have aspiration from this fluid inside to have all the cytology testing on the fluid. I will go with anyone. It doesn't matter.
Just if I can add a comment, I fully agree with
Sure.
most of.
You are the boss. You can comment. Mark, you are the boss. You can comment anytime, huh?
Thank you very much. But I don't want to speak too much. No. Just to say that now with solid tumor, I think we are all using only FNB and no more FNA for solid tumor. And with the FNB use, we have less than 10% of inconclusive pathology call examination. I think you all agree with that. So maybe the message, the take-home message is use only FNB for solid tumor and no more FNA. I think this is the first conclusion. And also, if you want to do any immunostaining, which is more and more important for following chemotherapy, you need, of course, FNB more than FNA. Okay, so less than 10%. If I have an inconclusive pathological examination, I look to the clinical case and to know if I need to do a second biopsy. And usually I do a second biopsy.
Okay.
Yeah, no, I completely agree. I mean, I don't think we should be using FNAs for solid lesions at all. I mean, for cystic lesions, there is a little bit of data suggesting perhaps better yield with FMB compared to FNA, but not a lot of literature. And so there's some other questions from the audience, shifting now to the lambs, and there's anxiety around deploying the proximal end of the phalange, because you don't want it to deploy inside the cystic cavity and whatnot. And so a couple of questions here is it important to see the proximal phalange endoscopically before you start deploying it? And also, what is your preferred technique for deploying the proximal phalange? Is it to deploy it within the scope channel or under direct endoscopic visualization?
Okay. So this is a very, very important question, and I think this is always what we do. So you should always have the proximal flange deployed under endoscopic control. This is clear. What I showed today, I showed a little bit also was combined with endoscopic, and this new camera mimic the X-ray, just to show you that you can do it with different facilities, I would say. But on the other side, on daily practice, you should always have the endoscopic view to see the proximal flange. What is my technique? When I release the distal flange, I will pull back my catheter to see on the tip of the scope this black mark, and to have this black mark inside the working channel. And then I will start having the last point of deploying the proximal flange inside the working channel of the scope, and then I will push the catheter to have it to push to release the proximal flange. And this is why I'm sure always every time that you have the proximal flange of the stent deployed inside the gastric lumen, not inside the cystic region. And just one comment here, which is I will not take any more time for the to keep on track, but this is very important. My only message that you should not, yes, release the stent inside the lumen. This is why training is very important for before using such technique. But on the other side, if for any reason this happened and you have the stent released, both of them inside the cyst, what you need to do immediately on the same presentation, and please correct me, professors, if I'm wrong, you need to have a pigtail inside this drain. You need to have access for this collection, because the second step, it will be leave the pigtail and come back after a couple of days, dilate, and bring this misplaced stent. Because very important. I have a lot of questions coming sometimes of my friends. Okay, if I release it wrong inside, what should we do? My very small advice here: you should always have an access, and then we can remove it in a second session.
Maybe Mustafa, I can say we have a paper about that, about have we to leave a double pigtail stent inside the lumen of lamp stent or not. And in fact, in this paper, it was exactly the same results with double pigtail stent inside or no double pigtail stent inside the lamps, except for food impaction. So maybe I'm not sure it's very useful, but for pseudocyst drainage or one drainage, I think it doesn't matter. You have no risk for doing that. It's
no, yeah, you are correct 100%. No, I'm not saying about the usual drainage. I'm saying if you have, if one of the physicians have wrongly deployed the stent both flanges inside the collection. So what we should do. So my advice here, if you have in this very rare condition that you have wrongly placed both of the stents inside the collection.
Okay. I understand. So if you have this case, first it means that your learning curve is not good, because you have not to release your stent inside the lumen of the pseudocyst, because if you see the black ring, you cannot release the lamps inside the pseudocyst. It's not possible. So this is the reason for why my advice is always to see endoscopically the black ring and not to put it in the operating channel scope, because if you're not sure about the location of the black ring, you have the risk of releasing completely the stent inside the pseudocyst. And the second point, for instance, if you are doing gastroenteral anastomosis, if you put the black ring inside the operating channel, you have a risk of dislodgement of the distal flange from the small bowel. So my advice is, I think this is a safer way. Always see the black ring, at least a part of the black ring, inside the gastric lumen. I think this is safer, not to release the stent inside the cyst, or not to dislodge the stent outside of the cyst or of the jejunum. This is my way to work, and this is what I am teaching to my fellows, because I think it's safer.
It is the best way to do. There is only few situations where you have to launch the stent inside the channel of the linear scope. Maybe sometimes in the duodenum it is most difficult, because you don't have any spaces to launch the proximal flange. But most of the time, it is best way to see the black rupert, the black landmark, as you said. Yes, I agree.
Linda, what do you think?
No, I completely agree. I mean, that's always the most anxiety-provoking part is, oh my gosh, you don't want to deploy, obviously, the proximal phalange, inside the cyst cavity. And so I completely agree. It's vitally important to make sure that you're seeing that before you start deploying the proximal phalange. And I usually have a little bit of back pressure as I'm deploying the proximal phalange, but obviously not a lot, because then I don't want to pull the distal side out as well.
And Ankit, what is?
I agree. Yeah, I agree. I agree completely with you. And Jeffrey, you said maybe in the duodenum when you're doing a CDS, maybe you don't have that much space. So perhaps in that situation, perhaps you can, yeah. So that's the only place where you have sometimes difficulty visualizing it endoscopically all the time. But I think visualizing and then deploying is the best way.
Okay.
Now, there's another question from the audience, actually, kind of shifting back to diagnostic EUS now. There's an audience question that's asking about how do you select which size FNA needle, and I guess we can say FNB as well, that you're going to use based on where the lesion is located and what it looks like.
Okay, so yeah, this is another great question. So for me, standard is the 22 gauge needle, which is I always use, I will say, in 90% of the scenarios for solid lesion. Sometimes I will use a 25 gauge needle, FMB needle, in very small lesion, most probably in small lymph nodes, sometimes in mediastinal lymph nodes, sometimes in a very difficult small lymph node, which I needed to take it from the duodenum, where you have the scope not in a very straight position and a little bit in a kinked position. So this times where I use the 25 gauge needle, but I would say 25 gauge needle in very small lesions, in very small lymph nodes and very difficult position. But rather than that, I will always go with a 22 gauge needle.
I think you're right, Mostafa. This is a very practical position and a statement, because, in fact, the comparison between 19 gauge and 22 gauge needle in the literature were done when FNB were not existing. So FNB changed everything. So I think it's not really a problem of diameter for the accuracy, but only a problem of FNB or FNA. But I agree with you that for small lymph nodes, it's easier with 25 gauge needle, because sometimes it's difficult to penetrate inside the lymph node, because they are moving away, they are rolling a lot, and sometimes it's very difficult with 22 gauge needle. So for small lymph nodes, I think it's better to use 25 gauge needle. And the last point about technical issue and accuracy is about the morbidity. Morbidity is mainly bleeding. And we have no clear answer in the literature about do we decrease the risk of bleeding, for instance, for NET tumor, neuroendocrine tumor, using 25 gauge needle. It's not clear. If it is more risky to use 22 gauge or 25 gauge. So what is the opinion of all the experts here?
I think that the 22 gauge is the best ratio between risk and benefit. And finally, since we obtained the FNB platform, there is no place for the 19 gauge needle, and all the different bleeding adverse events we observed in the past were due to the 19 gauge needle. I don't think what you think. I don't know what you think, but I think that it was very close related to the 19 gauge needle.
Yeah.
Yeah, I mean, I would agree. I mean, this is just anecdotal, but I haven't noticed any, increased bleeding with using a 22 versus a 25, even in neuroendocrine tumors. So I usually like to use a 22 unless it's a very small neuroendocrine tumor or something like that.
Yeah, same. I haven't encountered any problem with a 22 gauge needle in terms of bleeding from a neuroendocrine or any other vascular tumor.
And I guess, I mean, if for some reasons people don't have FMB needles available and, all they have are FNA needles, then perhaps in that kind of situation, you might think about using a 19 gauge in solid masses or something. I mean, that's the only time I can really think of using that.
I think I totally agree about this, but sometimes the problem of a 19 gauge needle and FNE needle, especially if you are taking from the head of the pancreas, sometimes the mobility and the positioning and even pulling the style, it is very difficult. So technically, sometimes it's very challenging to have this big needle, especially when you are taking from the head. This is why I tried my best to go tendency to do more on FMB, a 22 FMB, more than a 20 or more than a 19 FNA.
Yeah, no, I completely agree. I mean, I would only resort to that if for some reason you did not have any access to FMB needles.
And especially in submucosal tumor, because the only complication I had with submucosal tumors with 19 gauge FNA, when FNB were not existing, and I had some huge hematoma after. And so I think it was changed by the use of 22 gauge FNB needle. It's less risky. I don't know about you. You had some complication of hematoma or bleeding with submucosal tumor? No.
Thankfully, no. Maybe we just haven't done as much as you have, Mark. So.
No, it was mainly in submucosal tumor located in the duodenum. Okay. So maybe we can simplify for our attendees. So we need 19 gauge FNA needle for therapeutic EUS. We need 22 gauge FNB for solid tumor. And we need 25 gauge FNB or FNA for small lymph nodes, for instance.
Yes. Okay. And finally, please, if you have pathologist, push him to attend the procedure to help us.
Okay, so next guideline is closed. Guideline is performed.
It's an expert consensus.
Don't forget my name in the guidelines, please.
So finally, we are losing a lot of time for the guidelines. It's very easy to do.
Okay.
No,
so thank you very much. Thank you all of you.
Okay, Mustafa, you are leaving?
Yeah. I think the hands the control pushing that it's my time is off, so I will leave. Thank you very much, and hopefully we continue a great day.
Okay, thank you.
Thank you.
Just a question to Ankit, because we have a huge controversy in the literature about the risk of bleeding after necrosectomy, especially when using lamps, and the risk in the literature is about 15% at 1 month, and so the recommendation at 1 month is to do CT scan, and if you have no more significant collection, you have to retrieve the lamps and to exchange with double PTL stent. Do you agree with that? Is it your practice?
Yes. Agreed. 100%.
Yeah. But I have to say that I was very surprised by the high rate of delayed bleeding. And maybe what is not evaluated or assessed is the role of PPI. Because a lot of endoscopists said that you have not to use PPI when you are doing necrosectomy, because with the gastric acid, you are cleaning the collection. But in fact, if you let gastric acid, you have the risk of damaging the wall of the vessels and increasing the risk of bleeding. So I am using always PPI, double dose of PPI, but not tablets. Tablets under the tongue, sublingual tablet, because if you swallow a tablet is going inside the collection and is not efficient. So this is very important to know that. And I have no more bleeding doing that.
we are using a PPI which comes in a powder form as well, so that can be swallowed with liquid. So that does not. So we are. I did mention in my presentation that use of PPI may decrease risk of bleeding, but again, there's no scientific data to back this theory. So we'll have to perhaps do some studies to make sure whether the PPIs do help.
So you use a double dose PPI just for the duration that the LAMS is in?
Yeah, 4 weeks.
Exactly, 4 weeks.
3 to 4 weeks.
Yeah, exactly.
So there's one question about liver biopsy. Someone has asked about what kind of needle and what technique do you use for liver biopsy?
Before the use of the existence of FNB, I was gauge needle. But it was not very good results. And now, since I use 22 gauge FNB, I have no more problem for liver biopsy. We have always good results. And you? Linda and Geoffroy and Ankit, what are you using? 22 gauge FNB?
I personally I use a 22. Yes.
Yes, I use the same thing.
Yeah. And it really increased the accuracy of liver biopsy with EUS.
Yes.
And there's a question here about when to avoid using negative suction. I'm assuming during FNB or FNA.
I think it's very difficult to answer to this question because you know all the different way, wet suction, slow pull-out style technique, and suction, strong suction were evaluated with FNA needle and not with FNB. So when we compared with FNA needle, the accuracy was the same despite the different way you can use. Okay, so all the way to get a biopsy or a cytology was the same. For FNB, I have no scientific answer to this question. I'm always using suction. If the lesion is hypervascularized, I try to have the less suction as possible, but that's all. And you?
Yeah, no, I personally agree. I usually use suction all the time, whether it's capillary action with slow pull or syringe suction. And the only times I'll stop suction will be if I start seeing bloody specimens or, as you said, if they're vascular looking specimens or vascular looking lesion. So I think we have to end the session now so that we stay on time.
Yeah.
But this was fantastic discussion. Yeah. Thank you so much, everybody.
A long discussion, but very interesting discussion. And so, Linda, Ankit, and Geoffroy, I was very pleased, and I think all the attendees were very pleased from your answer, your questions, and your animation. So again, thank you for everything, and we are going to move to the session 5. So have a good day, and again, thanks a lot to everyone. Okay.
Thank you.
Bye. Bye.